Introduction of this new group of drugs called new oral anticoagulants was a groundbreaking advance in the whole anticoagulation therapy. This group of drugs are as effective, at least as effective as old drugs called warfarin and acinocumarol, but some of them are more effective than warfarin, like the bigatran. It's more effective in preventing against ischemic stroke for our patients with atrial fibrillation. At the same time, they are safer than warfarin. They cause less bleedings and especially less intracranial bleedings, which is also a very big advantage of new oral anticoagulants. Moreover, they are recommended by the most important European Society of Cardiology. They are recommended as a first drugs and more recommended than old drugs, I mean warfarin. So at first, when this group of drugs was introduced to the markets, it was a challenge to make a choice which drugs to use, because we had a lot of experience with old drugs like warfarin, and we had at first limited experience with new drugs. But over the years, from 2011 to 2016, we gained a lot of experience coming from precisely planned randomized trials and also coming from real life registries. And now we know that these drugs are effective, even more effective than warfarin, and at the same time safe.
I work in the emergency department. My colleagues in the anesthesia units, the surgical units, the intensive care units, and I have in the past had only non-specific approaches to removing the anticoagulant effect, the blood thinning effect of dabigatran when we needed that done in an emergency. Major bleeding, life-threatening bleeding, intracranial bleeding on dabigatran is very unusual. And the fact that it's unusual makes my team and me in the emergency department a little uncomfortable when these cases arise. If we were treating them every day, we'd be very comfortable and confident about how we're going to approach them. Because they occur infrequently, in the time before we had idarucizumab available, this was a significantly anxiety-provoking situation. Are we going to use prothrombin complex concentrate? Should we call the dialysis team? How are we going to approach this? Idarucizumab, the specific reversal agent for dabigatran, has been available in some jurisdictions like the US for over a year now. The response has been very, very positive. I like to tell my colleagues in emergency medicine that this is a great drug you won't have to use very often. And so many of them have not actually used it yet because they haven't seen a dabigatran-related bleeding issue that has risen to the level where there's a clinical need for immediate reversal.
Idarucizumab is an antibody, is a kind of protein which binds specifically to the dabigatran, is a specific reversal agent. And this binding is immediate and very potent, and it binds, this protein binds to the drug, to the dabigatran, with extraordinary, astonishing power. And this is a durable binding and very successful binding, and helps doctors to stop bleeding or to prepare patients for urgent procedures.
Idarucizumab has changed the emergency medicine and anesthesia and ICU approach to the management of dabigatran-related bleeding or reversal of dabigatran when it's needed for an urgent procedure by being very specific, single dose, one size fits all, easy to administer, no prothrombotic effect, that is, no activating the clotting cascade more than you want just by removing the dabigatran, in a way that practitioners can feel very comfortable that this approach is streamlined. They don't have to do complex dosing calculations. They don't have to mix anything together. It comes ready to pull out of a vial and inject. And it provides, as we've seen in reverse AD, complete and sustained reversal of dabigatran. So what the availability of idarucizumab has done for providers who work in the urgent and emergent care setting like I do is to simply take all of the guesswork and all of the estimation out of managing that rare patient whose dabigatran needs to be reversed. We simply give the drug, we know the dose, it's effective within minutes, and we can proceed with further stabilization and treatment of the patient.
I think that a lot of patients and also a lot of doctors, cardiologists, but also general practitioners were concerned about bleedings. And that is why a lot of people who deserve anticoagulant therapy were deprived of anticoagulant therapy because of this concern. I think idarucizumab gives us, both doctors and patients, this sense of security now that we can reverse anticoagulant effect within minutes with idarucizumab and help our patients. So the main message would be to use anticoagulant therapy in patients who need it, not to be so much concerned about bleedings because they are rare. And in the majority of cases, we can use ordinary measures to stop bleedings. We can use such measures like local compression, like gastroscopic methods, like surgical methods. But in some life-threatening situations, which are extremely rare, we could use idarucizumab for patients who are on dabigatran on a regular basis. And this is an extremely successful therapy, which is a great advantage in anticoagulant therapy as a whole. And I think it's a groundbreaking achievement in anticoagulant therapy that we've got this successful reversal agent. We can reverse anticoagulation within minutes and help to save our patients.
Both the NOAC prescribers, the primary NOAC prescribers out in the office setting who will never use idarucizumab because this is an emergency care drug, and those in the emergency care setting who may use it once a year, maybe once a career. These, again, are rare clinical circumstances, can all share in the confidence that comes from knowing that there's a reliable, specific reversal agent should those untoward circumstances arise.